The topic for the presentation is Principles and Mode of Action of Functional Appliances. So, we'll start with the contents that will be covered as a part of this presentation. So, it would include introduction, history, how it all began, anatomy of TMJ and muscle physiology, basic principles of functional appliance, theories of growth and functional appliance, mode of action of functional appliances, literature review, summary and conclusion, and finally references. So, the term dentofacial orthopedics conveys to the patient that treatment can significantly alter and improve facial appearance in addition to correcting irregularities of teeth. So, dentofacial orthopedics claims to correct facial appearance along with the routine orthodontic treatment to correct the irregularities of teeth. Now, to achieve this, functional appliances are the orthopedic tools used to influence the facial skeleton of the growing child in condylar as well as in sutural areas. Now, as we all know, function is inherent in all cells, tissues, and organs, and it influences these media as a functional stimulus. So, the goal of a functional appliance is to use this functional stimulus, channeling it to the greatest extent the tissues, jaws, condyles, and teeth can allow. So, functional appliance aims to improve the functional relationship of dentofacial structures by eliminating unfavorable developmental factors and improving muscle environment that envelops the dentition. And this is done by causing an alteration in position of teeth and supporting tissues so as to form a new functional behavior pattern or engram to support this new position of equilibrium. So, functional appliance in a crux work by harnessing the natural forces, guiding and transmitting the favorable ones, at the same time eliminating the unfavorable ones. So now we'll talk about the classification of various functional appliances. So functional appliances can be broadly classified into three groups. Group 1 includes appliances like inclined plane and oral screen, which act by transmitting the muscle force directly to teeth. Group 2 include appliances like activator and its modifications, which act by transmitting muscle force not only to teeth but to supporting structures as well. And group 3 include Frankel functional regulator, whose major operating area is vestibule, that is outside the dental arches. So now we will discuss how it all began. Starting with the history, we'll first talk about Rooks, who in 1883 did a study on tail fins of dolphins. He found out that there is an influence of natural forces and functional stimulation on form. According to him, it is that functional stimuli that is responsible to build, mold, remold, and preserve tissue, and he called this the shaking of bone hypothesis. Following Rook's hypothesis, Hoppel applied this hypothesis to correction of jaw and dental arch deformities. According to him, functional appliance worked through activity of orofacial muscle, which was proven over the years. Hoppel called functional appliances transformators. According to him, functional appliance was used to transfer the muscle forces from one area to another, wherein the mode of channeling was passive, and according to him, it was the intermittent force which was required for the buildup of tissue and had to be incorporated in functional appliance therapy. Following Hoppel, Schwarz in 1952 gave a hypothesis regarding activator, which at that time was a very popular functional appliance. That activator worked by intermittently transmitting functional force stimuli as well as applying light compressive forces. So, following all these theories, Many other functional appliances after activator like Bionator, Twin Block, Frankel functional appliance, Frankel functional regulator were introduced, whose mode of action will be discussed as a part of this seminar. So, before we talk about different appliances and their mode of action, let's first discuss the anatomy of TMJ and the muscle physiology. So, TMJ, as we all know, is the temporomandibular joint. It consists of the mandibular condyle and the glenoid fossa. It is a synovial joint, it is a diarthroidal joint. The synovial fluid is present in the joint cavity, which is divided into two parts, superior joint cavity and inferior joint cavity, with the help of an articular disc. Articular disc has three parts, three regions, that is anterior region, intermediate region and posterior region. It is the posterior region that has the most abundant neural and vascular supply. Along with this, there are many muscle and ligamentous attachments as a part of temporomandibular joint. Now, moving ahead to muscle physiology. So, there are two types of contraction, isotonic contraction and isometric contraction. Iso means same. So, if your tone will remain the same, you will call it isotonic contraction. In this case, the length will change. If your length will remain the same, you will call it isometric contraction. And in this case, your tension will increase, causing the contraction. After discussing isotonic and isometric, let's now discuss how appliances were classified based on muscle physiology. So they were classified into two groups, myotonic and myodynamic. Now what does tone means? It means the resting pressure and the muscle mass. So if the appliance uses the muscle mass or the resting pressure to act, you will call it as a myotonic appliance. For example, activator, as it was used later with the increased bite opening, which will be discussed further. Then, if your appliance uses muscle activity or its movement for the action, you call it myodynamic appliance because it is dynamic. It is using the muscle activity. For example, Bimler's appliance. So let's now first discuss myotonic appliance. So earlier, Anderson's activator was not a myotonic appliance. It was in fact a myodynamic appliance. Anderson's activator was earlier a very loose appliance wherein the muscle activity was put into use. However, to attain this, we had to construct the activator at the physiological rest position, because of which there was a major limitation that there was a loss of appliance during sleep. So, to overcome this, the interocclusal distance was increased, but now this completely changed the mechanism of action of activator, and now it became a myotonic appliance from a myodynamic appliance, because since now the opening is increased, it is the muscle mass and muscle tension that is put into use for activator to act. After myotonic, let's discuss about myodynamic appliances. So as we discussed earlier, Anderson's activator was a myodynamic appliance, but at that time, there was one big problem with activator, that it had a reduced efficiency. And this reduced efficiency was because of it being a bulky appliance with so much acrylic and because of the reduced elasticity. So to overcome this, Bimler's appliance was introduced, which reduced the bulk to allow 24-hour wear time, and it increased the elasticity so that muscular movements could be translated in a more effective manner to both dentition and supporting structures. After discussing this, let's discuss about the two very important reflexes, that is myotactic reflex and the clasp knife reflex. So myotactic reflex activity of the protractor muscles of mandible, especially lateral pterygoid, is what is responsible to keep mandible in a forward direction, thus stimulating growth of mandible. Grood in 1952 suggested that this kind of reflex and adaptation is only possible when you have a small bite opening that is within physiological rest position. If you increase the bite opening, as was suggested by Woodside, then clasp knife reflex will take over the myotactic reflex. So, clasp knife reflex refers to a Golgi tendon reflex with a rapid decrease in resistance when attempting to flex a joint. And this happens when you stretch muscles way too much, because then it leads to a formation of a viscoelastic stretch, which then causes a rapid decrease in resistance, causing the clasp knife reflex. Now, moving ahead to basic principles of functional appliance. So there are various kind of forces employed in orthodontic and orthopedic procedures. However, mechanical appliances like the fixed appliances, they mostly use compressive forces and pressure tension. It is a functional appliance that put tensile forces to use to alter the stomatognathtic muscle balance. So there are majorly two types of forces, external forces and internal forces. External forces are primary motivating forces. These are the forces that are produced by the occlusal and muscle forces of lip, tongue, and cheek. Now, these forces form the external load, and then in response to this external load, our tissue reacts, and these are called as internal forces. So these internal forces then lead to secondary tissue adaptation. So first there will be an external force. This external force will lead to reaction in a tissue, that will lead to formation of internal force, that is deformation, and then this deformation will cause secondary tissue adaptation, thus leading to various treatment effects. So, just as we discussed, the primary objective of functional appliance is to harness the natural external forces, transmit them to selected areas to produce a desired change. This causes strain and deformation of the tissue, which is called as internal force, and this eventually leads to remodeling and displacement and the treatment effects that are desired. So, what are the quantitative differences in force application? So, earlier it was believed that with functional appliance, the forces should be intermittent for 12 to 16 hours. They should be consistent to prevent the jiggling effect, and they should be small, because if they will be too much, then the compliance will be very less. But all of these things, especially the force being intermittent, was challenged over the years, which we will talk about later. So, what are the basic three treatment principles of a functional appliance? It is force application, force elimination, and neuromuscular response. First, let's discuss about force application. So, force application is nothing but a compressive stress and strain, which will primarily cause a alteration in form, and that will lead to a secondary adaptation in function. However, when we talk about force elimination, it is any unfavorable force or a restrictive force that we are eliminating. So, by eliminating, first we are rehabilitating the function, and following the rehabilitation and function, there will be secondary adaptation in form. Along with the secondary adaptation in form, there will also be a viscoelastic displacement of periosteum that will take place. That is known as the periosteal pull, which will be discussed as a part of Frankel appliance later as well. So now this periosteal pull, which is initiated with the help of lip pads or lip shields, leads to a tensile strain that I talked about earlier, leading to an osteogenic response. So now whenever you will apply a force or you will eliminate the force, there will be a tooth movement. And this tooth movement will happen because you're altering the balance of forces that is acting on them. After discussing the two major principles, let's discuss about the third principle, that is the neuromuscular response. So the functional appliances can incite sensory stimulations to trigger a neuromuscular response. So it is important to note that children with poliomyelitis or cerebral palsy cannot be treated successfully with functional appliance therapy, because they cannot trigger a neuromuscular response that is required. Now let's talk about the various theories of growth and their correlation with different principles of functional appliances. So if we discuss about force elimination, that is produced by the vestibular screen or the shields of Frankel appliance, the theory that comes into play is functional matrix theory, which was given by Melvin Moss in 1962. So just imagine that you have the vestibular screen and the screen extends the capsular matrix to a more normal space. By extending it to a more normal space, it will create an artificial shell. And according to this artificial shell, your dentoalveolar structures will get remodeled. And how it will act? So this artificial shell will remove all the deforming forces, and it will allow the teeth and alveolar processes to contact the matrix until and rehabilitate it until the patient can produce or lead to normal function without the help of this artificial matrix. So this artificial matrix does nothing but to eliminate the force and guide the favorable force and give us the desired result. After talking about force elimination, let's talk about force application and neuromuscular response. So, the theory that comes into play here is the servo system theory, which was given by Petrovic in 1982. So, if the posture of mandible is altered by functional appliance, the neuromuscular adaptability to this new spatial skeletal relationship is possible only with the help of a sensory input. So, just like in a computer, Petrovic suggested that the appliance works by three processes. There will be an input that will lead to a command, and the command will lead to an output. So, what is the input? It is the functional appliance that the patient is wearing. So, when the patient wears the functional appliance, there will be increased contractile activity of lateral pterygoid muscle. This will cause intensification of repetitive activity of retrodiscal pad, and this will eventually lead to increase in the growth stimulating factors. So the release of growth stimulating factors and the reduction in the local regulator, this is what we call the command. So once this command is given, then an output is produced, which is change in condylar trabecular orientation, additional growth of condylar cartilage, and finally supplementary lengthening of the mandible. So after talking about the principles, let us now talk about the mode of action of various functional appliances. So first, let's talk about Anderson's philosophy of activator. So according to Anderson, activator induces a myotactic reflex which stimulates isometric contraction. I would like to recall isometric means that the length will remain the same, the tone will get altered, which will lead to new mandibular closing pattern and which will induce musculoskeletal adaptation, that is growth of condyle in the upward and backward direction. So this philosophy was the earliest philosophy of activator, which was given by Anderson and Hoppel in 1995. But this met a lot of conflicts, and eventually there was three schools of thought that were formed. According to Petrovic and McNamara, this myotactic reflex will only act when our opening will be less than 4 millimeter. So after this, Woodside suggested to open the mandible by 10 to 15 millimeter, because according to him then stretching of soft tissue will occur, viscoelastic property of muscle will be initiated, and a clasp knife reflex will come into play. But Eschler said no, it's better to use a combination. Instead of opening the mandible by 10 to 15 millimeter, let's just open it by 4 to 6 millimeter and use the combination of effects of both isometric contraction and viscoelastic properties of muscle. So these were three schools of thought regarding activator. After activator, let's talk about bionator. So Anderson believed in force application, but Bolter believed in force modulation. According to Bolter, there is a equilibrium between tongue and circumoral muscles, and that is what is responsible for the shape of dental arch and intercuspation. But Bolter thought that tongue is actually the most important part in treatment. According to him, the neuromuscular envelope should be given secondary consideration because it is the tongue that exerts 3 to 4 times as much force on dentition as does buccal and labial musculature, which was said by Winders in 1958. So Bolter concluded that with the help of a bionator, muscle activity can be modulated, which can enhance the normal development of inherent growth pattern and eliminate the deforming environmental factors. So he incorporated these three features in the appliance, that is edge to edge bite, labial bow and palatal bar, and making the appliance less bulky. Now, why edge to edge bite? So, we just discussed that if our bite opening will be less, that is less than 4 millimeter within the physiological rest position, then isometric contraction will come into play. So, he had put into use isometric contraction. At the same time, the more important factor here is he didn't open the mandible more, he ensured edge to edge bite to prevent the tongue thrust from developing. Along with that, he incorporated labial bow and palatal bar to relieve the forces of labial and buccal musculature. And since he involved more wires and less of acrylic, the appliance was less bulky and there was better compliance. After talking about bionator, let's talk about functional regulator. So Frankel believed that no, tongue is not more important. According to him, it was the buccinator mechanism and the orbicularis oris complex that actually had the potential restraining influence on the outward development of dental arches. Because according to him, much of tongue function may be compensatory or adaptive to dentoalveolar morphology and not really the causative agent for causing malocclusion. So, according to him, during deglutition, there was a negative pressure within the oral cavity that led to constricting influence on the dentoalveolar process and prevention of eruption of buccal segments. So, he decided to create an ought to be artificial matrix similar to the vestibular screen that we just discussed. So, he will create an artificial matrix allowing the muscles to adapt to the artificial matrix until they can do without it. So it included buccal shields and lip pad to hold buccal and labial musculature away, allowing optimal downward and outward movement of both teeth and investing tissues. Along with just the force elimination, he also ensured to include a periosteal pull by extending these buccal shields and lip pads into the depth of the vestibule so that the tissue can be under tension, which can cause pull on the contiguous periosteal tissue of both maxillary and mandibular bone, allowing basal bone widening as thin alveolar shell over the erupting teeth proliferated laterally. After Frankel, let's talk about twin block. So Clark's philosophy believed in using bite blocks to modify the occlusal inclined planes. He aimed to achieve rapid functional correction of malocclusion by transmitting favorable occlusal forces to occlusal inclined planes covering posterior teeth. So, according to him, occlusal inclined planes were the fundamental functional mechanism of natural dentition. According to him, occlusal forces were transmitted through dentition to provide constant proprioceptive stimuli to influence growth rate and allow adaptation of trabecular structure of supporting bone. The occlusal inclined plane allowed greater freedom of movement in both anterior and lateral excursion. So there was less interference with normal function, which was a big problem in activator and bionator. Therefore, this allowed a wear time of 24 hours a day, wherein masticatory forces could also be put into use in the activity of functional appliance. So the twin block consisted of acrylic inclined planes on occlusal bite blocks interlocking at 70-degree angle. By removing the unfavorable cuspal contacts and replacing them by favorable proprioceptive contacts of modified inclined plane, these occlusal inclined plane acted as a guiding mechanism, displacing the mandible both downward and forward. However, with twin block, the muscle behavior was immediately influenced through placement of inclined plane between the teeth, but eventually the functional appliance took some time to alter the underlying bone with the help of the sensory receptors in the masticatory muscle, teeth, and surrounding tissue. Functional response in the underlying bone was eventually stimulated. Now we'll talk about literature review. So, after discussing the mechanism of action of various functional appliances, let's try to summarize the mechanism of action of functional appliance on an overall basis. And this article can be of huge advantage here. So, this article, the influence of functional appliance therapy on glenoid fossa remodeling, was published in Ajo DO in September 1987. And now we will discuss the various factors that they discussed as a part of the mechanism of action of functional appliance. So to start with the first one, the mandibular growth induction. So there were two schools of thought. One school of thought believed in intermittent force application and another believed in continuous force application. As we all know, activator had intermittent force application wherein it was only used at night. But there was a study done by Jacobson, Harwold, and Wargewick. Jacobson did a study in 1967, Harwold and Wargewick did a study in 1987, and they concluded that activator treatment found no significant changes in mandibular body length. However, when Herbst appliance was used, according to a Pancher study in AJO-DO in 1979, they reported an increase in the mandibular length using Herbst appliance. Therefore, according to this article, it is the continuous force application that plays a better role in altering the mandibular length. Talking about redirection of condylar growth, so studies suggest that functional appliance treatment of class 2 malocclusion may induce favorable change in condylar growth direction. It is likely that such changes represent remodeling of various areas of mandible to produce changes in form. Talking about the third factor, that is deflection of ramal form. So, animal experiments in mandibular repositioning and human functional appliance studies both have reported changes in gonial angle. It appears to be a result of remodeling in response to altered activity and tone in masseter internal pterygoid sling. Talking about the fourth factor, that is horizontal expression of mandibular growth. So, on removal of adverse environmental influences such as severe airway obstruction, it may be followed by a more horizontal mandibular growth direction. Whenever we use posterior occlusal bite blocks or functional appliances, and functional appliances as in twin block, uh, with the occlusal bite blocks, they inhibit the buccal segment eruption in both the arches and produce a more horizontal mandibular growth direction in children with excess lower anterior facial height. This is how we treat the patients with vertical growth pattern using twin blocks by ensuring not to trim the bite blocks and maintaining the growth rotation as it is, maintaining the rotation of mandible as it is. Talking about the fifth parameter, that is maxillary growth restriction, it has been shown that an important factor in achieving class 2 correction in both removable and fixed functional appliance is restriction of forward maxillary growth, which we call the headgear effect of a functional appliance. Talking about the sixth factor, that is dentoalveolar changes. So, many studies have reported distal movement of maxillary teeth and mandibular anchorage loss, that is proclination of lower anteriors with the help of Herbst appliance. Talking about the seventh factor, that is glenoid fossa relocation. So, as we all know, glenoid fossa normally grows in a posterior and inferior direction. However, during functional appliance therapy, fossa is reported to grow in reverse, thus relocating the fossa to anterior inferior direction to meet the active condylar modification and restore normal function. Talking about the eighth factor, that is changes in neuromuscular anatomy and function. This is the last factor that will be discussed here as a part of this article. So, functional appliances modify the neuromuscular environment of dentition and bone. Adaptations such as elongation of muscle fibers, tendons, and migration of muscle attachment is what is responsible for altering the neuromuscular environment. Now, moving ahead to a very important concept, that is growth relativity hypothesis. So, this very popular sensational article was published by Woodrose in AJO-DO in March 2000, and he completely changed the whole ideology by talking about the demise of the lateral pterygoid hyperactivity hypothesis. So, according to him, the attachment of lateral pterygoid muscle to condylar head or articular disc is what is expected to cause the condylar growth. If we are thinking that it is the lateral pterygoid muscle contraction that is only responsible for the activity of functional appliance, then the attachment should also be like that. The attachment should be to the condylar head or articular disc. However, anatomic research has found no evidence that such significant attachment actually exists. Instead, the lateral pterygoid muscle tendon attaches to the anterior border of fibrous capsule that in turn attaches to the fibrocartilage of condylar head and neck anteriorly. So the position of the lateral pterygoid muscle creates a doubt that whether it is solely responsible for action of functional appliance or not. Along with that, it is doubtful that initial hyperactivity could occur when lateral pterygoid muscle has been shortened by continuous mandibular displacement therapy. So, human studies conducted by Ofdermore, Panchers, Anihis, Panchers, Ingerville, and Bitsanis, they reported that there was in fact decreased muscle activity when functional appliance was used. So instead of hyperactivity, they observed a decreased muscle activity, thus again pointing out that lateral pterygoid muscle might not be the sole reason for action of functional appliance. So now, what specifically affects growth at condylar head? Enlow and Hans suggested that mandibular growth is a composite of regional forces and functional agents of growth control that interact in response to specific extracondylar activating agents. So these extrinsic signals are the foundation of the growth relativity hypothesis, which consists of a composite of all the regional forces and functional agents of growth control. So, growth relativity refers to growth that is relative to displaced condyle from actively relocating fossa. The growth discussed here is relative to long term retention results rather than short term treatment outcomes that are clearly different. So, growth relativity hypothesis has three main foundations. There is a orthopedic mandibular displacement. There is a stretch of non-muscular viscoelastic tissue, which include retrodiscal tissue, fibrous capsule, and synovium, and thus there is a forced transduction. So, the condylar growth is affected by viscoelastic tissue forces via attachment of fibrocartilage that blankets the head of the condyle. So, this analogy of a light bulb of condylar growth and retention will let us understand the growth relativity concept or hypothesis in a better way. So, let's just look at this image very carefully. So, whenever there is a orthopedic pull force, the condyle is continuously trying to advance. So this will lead to lighting up of the light. This will lead to a phenomenon which will be similar to lighting up of the light bulb on a dimmer switch. So just look at this picture. There is a orthopedic pull force. When there is orthopedic pull force, there is shortening of the inferior lateral pterygoid muscle and stretching of the anterior digastric muscle. Now, all of this will cause advancing of the condyle, and on advancement of the condyle, there will be stretch of the viscoelastic tissue. And when there will be stretch of the viscoelastic tissue, that is all the non-muscular structures there, it will eventually lead to forced transduction, which will cause the condyle to displace anteriorly and the glenoid fossa to also undergo remodeling to adjust to this new condylar position. And then when condyle is released from this anterior displacement, the reactivated muscle activity dims the light bulb and returns it to the normal growth activity. Now let's summarize all the appliances and their mode of action. So the first appliance, that was activator, acted by activation of the muscles. It acted by force application. Bionator acted by modulating the muscle activity, wherein the major role or the dominant role was played by the tongue. Oral screen acted by eliminating the force of perioral musculature on dentition. Lip pumper, again like oral screen, acted by force elimination. Frankel appliance acted by force elimination and by applying the periosteal pull to allow osteogenic response. And twin block, which is different from all of these, used the occlusal inclined plane, which acted as a proprioceptive stimulus to growth to allow condylar remodeling to occur. So, I would like to conclude by saying that success is neither magical nor mysterious. Success is the natural consequence of consistently applying the basic fundamentals. So, it is important that we never forget our basic fundamentals and we apply our fundamentals throughout the functional appliance therapy or any orthodontic treatment procedure. whatsoever. Here are the references. Thank you.